Okay, great. All right. Good morning, everybody. Thank you so much for joining us for the September ACC. I am really pleased to be welcoming Dr. Aley Kalapila, who is a professor of medicine in the Division of Infectious Diseases at Emory University School of Medicine. As many of you know, she is also an alum of our training program here at UW and remains connected to UW through her work on the National HIV curriculum and the National PrEP curriculum. She is a staff physician at Grady Hospital, the safety net hospital in Atlanta, and she's going to speak with us today about building blocks for healthy aging, key components of care models for older people with HIV. Dr. Kalapila, welcome. Take it away.
Okay. Thanks, Julie. Thank you guys all for having me. So as Julie said, I did my residency and my fellowship in Seattle, and now I am a faculty member in Atlanta, and I've been at Emory, but my clinical appointment is at Grady, which is our safety net hospital. And I do all of my outpatient care at our Ryan White Clinic, which is featured here in the top right column, which is this white building. It's the Ponce de Leon Center. It is our Ryan White Clinic that's associated with Grady. We have about 7,000 patients, which unfortunately is a testament to the HIV epidemic in the South. I take care, unfortunately, for a lot of young patients with very severe advanced opportunistic infections. So all this to say that I am definitely not an HIV, I'm not a geriatrician, and I'm not an HIV and aging expert. And so when I was asked to kind of give this talk, I was trying to think about what would be of use to all of you, because I know that most of you are providers that care for patients living with HIV. And I know that a lot of the time when we hear about talks on HIV and aging, there's a lot of focus on comorbidity screening and polypharmacy. And I wanted to kind of not necessarily focus on that, but take a little bit of a step back and kind of do a larger overview on how we can think about building care models for our patients with HIV as they age. So I've no financial disclosures, and then my learning objectives. So we'll review epidemiology and demographics briefly for HIV among older adults. We'll look at sort of 7 key components of care or care domains when you think about care delivery models for older adults with HIV. We'll talk a little bit about the challenges and controversies in each of these care domains, and then I will also give you some case examples of some models of care that exist for HIV and aging that have been written about or published in the literature, both in the US and in other countries. So let's talk briefly about epi. So patients with HIV are living longer thanks to effective combination antiretroviral therapy, and they're aging, right? So this is data from AIDSview, the most recent data, and this gives you a sense of the percentage of people that are living with HIV. On the left are patients ages 55 to 64, and on the right are patients who are 65 and older. And as you can see, this is not an insignificant number of people, right? This is a pretty large proportion of people. And in fact, a lot of the recent data coming out of the CDC suggests that there's about 50% of people living in the United States who are over the age of 50 and who have HIV. And globally, UNAIDS estimates say that there's about 8 million people living with HIV who are over the age of 50, which represents about 20% of the global population of individuals living with HIV. And there are estimates that say that by 2030, that's going to be 70% of the population. So our patients are getting older. And so we need to try to come up with care models that can allow them to age in a healthy fashion. So in order to do that, we have to combine the fields of HIV medicine and geriatric care. And how do we do that? How do we kind of meld these two together? And is there a framework that we can use when we approach aging care in all of our patients? So in general, it makes sense, right? As we get older, in order to, and really for all of our patients, but especially for patients as they get older, to have a positive effect on overall health and well-being, we need care models that address all of these 4 different areas, right? We need to be able to medically deal with HIV, multimorbidity, polypharmacy. We need to address our patients' psychological concerns, depression, anxiety, PTSD. We need to also address social issues, right, that affect all of our patients, but more so as they age. Patients might be are at higher risk for isolation and loneliness. And then we also need systems level, we also need to address, to screen for and address systems levels concerns, things like housing insecurity, food insecurity, et cetera, right? Because if you don't address all of these things, then it's going to be hard for you to get to feel healthy and for you to age effectively, right? We have many examples of patients that have extremely stable HIV and minimal comorbidity burden, but they struggle because of social isolation or because of substance use disorder or because they have housing insecurity or housing instability. And on the other side of the spectrum, you might have patients that have amazing social networks, and housing stability, but they are struggling because of significant HIV and multimorbidity burden. So when we think about models of care, we really do need to address all of these key areas. So a lot of the research that comes, that I've seen at least, and again, like I said, I'm not an expert, but this is just sort of a basic review at looking at care models for HIV and aging. A lot of this research really comes from sort of the ivory tower of academic medicine in high-income countries. And so they may not necessarily be translatable to resource-limited areas, right? And so how do we go about thinking about building an effective model of care for our patients that can be translatable and can be adopted into different areas and different communities. And so Eugenia Ziegler is a professor of geriatrics, and she does a lot of national presentations and has written papers on HIV and aging. And she and Emily Frey, who are geriatricians at Cornell, they wrote a paper recently about exactly this, about trying to think about care domains. And they kind of described 7 universal care domains that need to be addressed in order to create an effective care delivery model for patients living with HIV. And so these care domains are HIV management, comorbidity management, primary care, socialization and behavioral health, functional ability and geriatric syndromes, and then access to food, housing, and other services. And I'm going to kind of go over all of this individually and kind of talk about some of the things you need to think about when building an effective HIV and aging care delivery model. We'll talk a little bit about the challenges and also a couple of interesting, couple of papers, and then also maybe some screening tools that I found that are useful and that you can use when you're trying to screen in for all of these areas as well. So I'm first going to focus on HIV management and comorbidities. So I know I'm talking to a bunch of HIV providers, so I'm not going to belabor that. We know that antiretroviral therapy is recommended for all of our patients. And we also know that we are very fortunate to live in a time when we have extremely effective, safe, well-tolerated oral and injectable antiretroviral therapy options that have minimal toxicities and are high potency, right? And we know that patients with HIV, and certainly older patients with HIV, when started on antiretroviral therapy, promptly experience a significant survival benefit and a marked reduction in their AIDS and all-cause mortality. But on the flip end of things, we need to also consider when we think about caring for the aging patient is that this isn't a one size fits all, right? Our patients, as they get older, have comorbidities, are at risk for polypharmacy. And so what might work for a 20-year-old is not necessarily going to work for a 65-year-old. Also, older patients, particularly those who are long-term survivors, might have complex HIV mutations. And so we might have to think of complicated regimens or salvage regimens to treat them. On a more systems-based level, the things that we need to think about are that older people are actually underrepresented in clinical trials, right? Oftentimes, age cutoffs in clinical trials can limit the inclusion of older individuals in clinical trials. And so, for instance, the FLAIR trial, which I think looked at comparing injectable cabotegravir rilpivirine to oral ART in virologically suppressed adults, the median age for that trial was 34, right? So think about that and think about how you can extrapolate that to your patient. Many clinical trials also have exclusion criteria like CKD or abnormal EKGs that will then, which are common in older adults. And so as a result, they are not included as much in clinical trials. So how do we translate all of that data into the patient that you see in your day-to-day practice, right? And so for things like injectables, other aspects we need to think about are also older patients are at higher risk for sarcopenia, less gluteal tissue, less muscle mass. So are injectables getting effectively absorbed? So these are all sort of systemic level concerns that we need to think about when in the care domain of HIV management. So moving on to comorbidities. So we've said that patients living with HIV, when they get effective antiretroviral therapy, we know that their life expectancy increases, right? But what about comorbidities? So this was a study that was done from Kaiser, and it looked at the life expectancy in comorbidity-free years among individuals in the Kaiser clinics in California and the Mid-Atlantic region and compared them to their peers who are HIV negative. And as you can see here from the two lines that you can see here, the life expectancy, the gap was pretty significant in life expectancy for individuals between individuals with HIV compared to those without. And that gap has significantly narrowed from 22 years to 9 years, and this was in 2016. And we know that that gap has even narrowed even further now, thanks to effective ART, if we look probably at numbers today. But when we actually look at comorbidity years, what you see here is that there's still a pretty significant gap in comorbidity years that our patients experience with HIV compared to their peers who are HIV negative, right? So what this is showing is basically that people with HIV are living fewer healthier years, fewer comorbidity years compared to peers that are HIV negative. So what's in some ways they're experiencing accelerated aging, right? So they have higher comorbidities at the same age, or experiencing comorbidities faster compared to peers who are HIV negative. So they're accelerated aging, but then we want to look also at comorbidity burden. So how many comorbidities do they get? And so I wanted to sort of highlight a study by my Emory colleagues. So Lauren Collins is the person who spearheaded the study, and she leveraged data from the MaxWise cohort, which is the largest longitudinal observational cohort of people living with HIV and in the United States with about 12,000 adults. And the MPIs of the project are Igor Fodorkin and Anandi Sheth, who are also my colleagues as well. And this was recently published in one of the JAMA journals. And so what Lauren did was she wanted to measure the comorbidity burden among people with HIV and compare it to peers, demographically matched controls individuals who did not have HIV. And she just wanted to measure comorbidities. And so this is the data from her paper. So the top slides, the top two graphs are individuals with HIV, and the bottom are individuals without HIV. And then on the left are women, and on the right are men. And the darker areas represent a higher comorbidity burden, so more comorbidities. And as you can see very clearly, individuals with HIV have a higher comorbidity burden compared to individuals without HIV. And also, if you look, it's also females are disproportionately affected, right? So this non-AIDS defining comorbidity burden is actually higher for individuals with HIV, and it differs based on sex, with a higher prevalence of non-AIDS defining comorbidities among women with HIV compared to other individuals. So in addition to our patients getting comorbidities earlier, they're actually experiencing a higher number of comorbidities as well. And so this is related to this model that we often talk about, which is that people with HIV experience both accelerated and accentuated aging, right? So they get comorbidities earlier, and they are also experiencing comorbidities more frequently as well. So when you have a patient with multiple morbidity, how do you take care of them, right? And this can be very challenging because when you have a patient who has CKD and heart failure and hyperlipidemia and atrial fibrillation, like how do you manage all of these things? Because each individual disease guideline is useful for that specific disease. But when you have a patient that has multiple things, oftentimes the guidelines can conflict with each other. So this was a paper that was published by Cynthia Boyd, who's a geriatrician at Hopkins, and she has published a lot in this area. And she kind of gives you a framework to think about patients and managing multimorbidity as they age. So on one end, if your patients have a normal life expectancy and they're extremely fit, then it probably makes sense to follow the disease-based guidelines as is. But for patients who are extremely frail or who have very limited life expectancy, we may have to think about de-escalation of care and managing more of their symptoms in order to avoid any significant morbidity or mortality. But the vast majority of our patients kind of fall in the middle, right? Like their life expectancy may not be completely normal, but it also may not be, they may not be at the end stages, but they do have multiple comorbidities that they suffer from. And so this really kind of like, you have to sort of take a step back and look at their life expectancy, but look at also their function and try to align your disease management with their own individual goals and what they want for their care. And so this becomes extremely important for our patients as they age and experience multimorbidity. So again, like thinking through this care domain and challenges with this care domain, right? So when patients have have a high burden of comorbidities, complex care coordination gets kind of challenging, right? When your patient has to see you and a cardiologist and an endocrinologist, this gets a little bit difficult trying to coordinate their care among care domains. Polypharmacy obviously is a very common thing that happens with patients as they age, and it can complicate our management. Screening guidelines for non-AIDS defining comorbidities can often underestimate disease risk in our patients. And then, of course, disease practice guidelines are focused on a single disease and how exactly do we effectively care for our patients when they experience multimorbidity in such a way that allows them to age in a healthy and effective, in a healthy manner. So moving on to another domain, which is primary care, attentive to priorities. So as HIV providers, I think we pride ourselves on being primary care doctors, right? But as our patients get older, it gets increasingly more challenging. Again, patients who are long-term survivors might have complex HIV resistance, and so regimens can get complicated. We just talked about the burden of multimorbidity, and managing that can get difficult. And then, of course, they're susceptible to aging-related syndromes, and they might have many complex social and behavioral needs. They might have mental health concerns that get exacerbated because of dementia or social isolation or loneliness. And it becomes extremely difficult to kind of address all of these things in our traditional model of primary care. And so these are some of the things that we have to think about for patients as they age. Another thing that we do pay attention to that I know I'm certainly not very good at is advanced care planning. And this is something that is an integral part of patients as they age, including for our people with HIV. But there's data that showed that this is very much underutilized. And oftentimes, the vast majority of patients, older patients with HIV, advanced care planning occurs in the acute setting when it really should be occurring in your clinic visits with for your primary care patients. And there are also barriers to this, right? So there's definitely barriers on the provider end because you may not be comfortable with discussing advanced care planning, but patients might view themselves. There was a study from the VA actually in Atlanta with a small number of Atlanta vets, and they did some focus groups to discuss advanced care planning, and they found that patients view themselves as survivors when they've lived a long time with HIV, and so they may not want to discuss what could happen near the end of life. Patients face stigma. There's low health literacy, substance use disorders. All of these things can impact advanced care, the discussion around advanced care planning. And I'll just tell you that this is an area that I've now been in Atlanta 11 years, and I'm starting to see patients that are now like experiencing aging-related syndromes, and I've started to think about wanting to do advanced care planning for them. But I've really kind of struggled some of that because I've not been able to necessarily explain things effectively to my patients because this is a complex topic to discuss, talking about advanced care planning. So I sort of went into the literature a little bit, and I found actually a resource that I did not know about at all. And so this is from UCSF. So Rebecca Sudor is a geriatrician at UCSF, and she and her group have published extensively on this. And she had done a pilot study where she developed a website, which is free, and it's called prepareforyourcare.org. And this website was built based on discussions, a large number of focus groups that were done in San Francisco in the safety net clinics among older adults and their surrogate decision makers. And they interviewed and worked with patients with a wide variety of literacy and educational backgrounds, and who were both English as well as and or Spanish speaking. And this website is sort of grounded in theories of social learning and behavioral change and communication. And rather than focusing on, asking patients, do you want CPR or do you want mechanical ventilation? What this website does is kind of really breaks this down and tries to explain to patients, what do each of these things mean, and then tries to teach them how to effectively clarify their own goals for what they would want for their care, and then how they can actually communicate that to their loved ones and to their medical providers. And so if you actually click on the website, like, it really kind of breaks this down into each different steps as part of the advanced care planning process. And then there are actually videos and action plans and stories. And this is done in English and Spanish, but when I looked, I'd seen that they're also trying to do this in other languages as well. So this is an excellent resource that you can use, and it's really done in a culturally sensitive fashion, and it is geared towards a fifth grade reading level. So again, it sort of works for people that might have lower limited health literacy as well. And so they actually did a randomized clinical trial with this. They did it where they took about 1,000 adults from San Francisco safety net clinics, and they gave them all easy to read advanced directives that they had already developed. And then about half of them, they gave them access to this Prepare website. And they measured engagement in advanced care planning. And this was measured by looking at whether or not patients were willing to discuss advanced care planning with their family members or with their providers. And as you can see here, so the dark lines are the dark graph is the one where patients only got advanced directives, easy to read advanced directives. And the lighter line shows patients that received access also to the Prepare website. And as you can see, among all participants, there was a significant engagement in wanting to discuss advanced care planning when they had access to this website. And the data that I didn't show here is that they actually followed these patients a year out, and this gap was this was sustained. Like, patients were willing, even a year out, to continue to engage with advanced care planning discussions when they had access to this website. So, again, like, I'm not saying that this website is the answer to discussing all of advanced care planning, but it sort of raises this, your attention to the fact that, like, you need to use different modalities to kind of to work with patients who might have limited health literacy in order to engage in these discussions in advanced care planning. Perhaps you can bring them into clinic and show them videos so that you can start to have a conversation, because this is not something that we can address in one single visit, right? This has to be a constant evolving decision with our patients. And this website at least gives you a starting point to kind of think about advanced care planning for your patients. So now moving on to socialization and behavioral health. So I don't need to tell anyone that as our patients in general with HIV are more likely to experience mental health concerns like depression and anxiety, as well as social isolation and stigma. And of course, all of this is exacerbated as we age. And then on the flip end of this, when we think about challenges, we have inadequate resources to address this. Mental health alone can be very stigmatizing. I will tell you that in our clinic, we have an entire floor dedicated with mental health professionals, where we have therapists and psychologists and psychiatrists. And even to walk up one flight of stairs, my patients will often refuse to go see a provider. And then we try to model where we have a psychologist or a therapist that sits down with us when we have our regular HIV clinic. And so sometimes when I'm seeing a patient and I think that they might benefit from talking to someone, I offer this option to them to be like, hey, I have a therapist right outside. She can sit with you and chat. And even then patients refuse. So mental health can be very stigmatizing, and that can prevent patients from wanting to engage in addressing those concerns. And then, you might have support groups that deal with, that work with individuals with HIV who have depression or anxiety, but are they geared specifically towards older adults, right? And then, of course, there's more systemic limitations as well. So there may be limited funding available for non-medical interventions like Tai Chi or increased social activities. So all of these things are considerations and challenges that you have to think about when addressing sort of this specific care domain. So I wanted to I just listed a bunch of tools that you can think about when addressing things like cognition, social isolation, and loneliness. Some of these you are familiar with, things like MoCA, or the International HIV Dementia Scale. But I wanted to draw your attention to a few other things. And I actually found a lot of these resources on a website that I'll show you at the end, and I've sent my slides as well, which you can get after this talk, which is from the New York State AIDS Institute. They have an entire clinical guidance on HIV and aging, and it is like chock full of amazing resources. And so some of this information I actually got from there. So to think about or measure or assess social isolation and loneliness, which our older patients might be susceptible to, there's this Campaign to End Loneliness, which is actually this extensive website from UK. It's an initiative in the United Kingdom that focuses on sort of measuring and interventions to address chronic loneliness. And there's a lot of validated tools there to measure degrees of loneliness and social isolation. The Berger HIV Stigma Scale is a very well-validated scale to measure stigma in our patients with HIV related to negative self-image or fear of disclosure. And it's a 40-item questionnaire that's, again, free to access. And then the New York State, again, this New York State AIDS Institute guidance on clinical aging has this entire HIV and intersectional stigma toolkit. So just, again, another potential resource that you can use. And they're apparently in the process of developing also a loneliness toolkit as well. So this is another great website that you can go to where if you wanted to think about evaluating and assessing loneliness, social isolation, and stigma in your patients. So then moving on to functional ability and geriatric syndromes. So of course, as our patients age, right, so you have changes in cellular senescence, changes in your metabolism, changes in your immunity, chronic inflammation, and all of these things form the aging phenotype. And this combined with, so the biology of aging, so this combined with genetics and environment, patients can lead to a lot of both functional as well as physical impairment, which then increases your risk for frailty, as well as other geriatric syndromes. And geriatric syndromes are basically are syndromes that patients, as they get older, can experience, which are as a result of an interplay of multiple different chronic medical conditions. So things like fall and urinary incontinence and delirium, and all of these things can kind of it's like a feedback loop with frailty. So it's frailty and these geriatric syndromes can reinforce each other and can cause poor outcomes leading to disability, dependence, and death. So it becomes important to address functional issues and aging and frailty in our patients. And so there's a lot of systematic reviews and cohort studies that show that older patients with HIV are especially prone to develop frailty and pre-frail conditions. They also develop geriatric syndromes and adverse outcomes related to this. So, and oftentimes if we are able to screen and identify patients early on, we can intervene, right? We can address specific risk factors and hopefully kind of slow the progression of their decline. And so the HIV/MA primary care guidance that was published in 2024, as well as the European AIDS Clinical Society as well, recommends annual frailty screening now for people with HIV over the age of 50. So how do you go about doing these assessments? So some tools that I found, again, online. So the first is the WHO, the World Health Organization, Integrated Care for Older People Handbook. And this is, again, a very, very detailed resource that looks at measuring intrinsic capacity in specific key areas. So things like cognition, mood, hearing loss, vision. And it provides you with tools that you can do to assess all of these key areas. And then it actually gives you recommendations for interventions, for digital and mobile apps that you can use for interventions, and how to come up with care plans to address deficits in each of these areas. And this handbook is not meant to be used just by you alone or by the geriatrician. It really has to be a multidisciplinary effort along with caregivers, nurses, and allied health professionals in order to address all of these different aspects of functional capacity. And this is a very involved toolbook, and I'll show you a slide that shows some of the content from here a little bit later. But in the New York State AIDS Institute website, they actually used that WHO ICOPE handbook, and they developed a much more concise screening tool that you can use. It's much more abbreviated and it looks at all of these key areas of intrinsic capacity. And you can actually, one of your non-clinical staff can just administer this to the patient at the start of a clinic visit. And if they're identified as having concerns or problems in any of these areas, then you can go back to the WHO handbook and try to do more detailed assessment. So for instance, if someone has a hearing issue or flags positive on the hearing screen, then this is just some of the more in-depth screening that they would suggest to evaluate for hearing loss. And like I said, this is just one page of many in this handbook, but this is a useful and free resource that you have available to you if you're thinking about addressing functional impairment in your patients as they age. Another toolkit that I think is very common for geriatricians is this comprehensive geriatric assessment toolkit. And again, this is a fantastic website that gives you many validated screening tools to address geriatric syndromes. And then this is another resource that I found, which is put together by Harvard Medical School. It is geared towards clinicians who want to assess frailty. And it actually contains an extremely well-curated collection of frailty screening tools that are geared towards different settings in which you might want to screen frailty. So you can actually sort through screening tools. Are you doing a brief assessment? Are you a geriatrician wanting to do a more comprehensive assessment? Or do you just want to do a quick pre-op risk assessment before the patient gets chemo or goes into surgery? So this is again, like I said, it's a fantastic and free website. And then it even sorts the frailty tools based on, do you just want to ask your patients a series of questions, or are you able to do a more physical assessment as well? So again, this is another great website that you can use when you want to assess frailty. So when you assess frailty, your patients can fall on a spectrum anywhere between fit to end stage frailty. And this was some guidance that was published in a New England Journal of Medicine review article on frailty. And again, it sort of makes sense, right? When your patients are more fit, you're going to focus more on applying your disease-based guidelines, focusing on prevention. And if they're at the end stages of frailty, then you're going to really want to emphasize more of de-escalation of care, and palliation. And if they fall in the middle, you want to identify any modifiable risk factors that they might have that can cause them to be more frail. So things like addressing vitamin deficiencies, addressing hypothyroidism. So really kind of focusing on treating the reversible causes of frailty when patients fall in the middle of this spectrum. So I've given you a whole bunch of resources and screening tools for frailty and geriatric syndromes and functional ability. But what do you use, right? And so this is a challenge for our patients. There's no real consensus on the best tools, when we need to use it, and also who we need to target when we do the screening. And as you can see here, these screenings are extremely time and labor intensive. It's certainly not something that we can do alone. We really do need a team in order to do that. And we have workplace shortages, both in geriatricians as well as allied health professionals. And we also might have limited access to evaluations, to rehabilitation services. And so if we're unable to come up with effective interventions once we screen someone and find them to be frail or find them to have a geriatric syndrome, then what's the point of screening in the first place, right? And so these are some of the things that we have to think about. And patients may also be not willing to engage. They may not want to have that geriatric label. They may say, I've come this far. I'm not old. I don't want to discuss this. And so that also can be a barrier in terms of when we think about screening for all of these aging related syndromes. So finally, just focusing on food and housing services. So I don't need to tell anyone here that the social determinants of health are important. Food insecurity affects a lot of our patients, and a lot of our patients have unmet housing needs. I know housing instability and homelessness are an issue in Seattle. It certainly is an issue in Atlanta. And then, of course, as our patients get older, with reduced income, social isolation, cognitive functional decline, all of these things can just get exacerbated. And our resources to address this in our care delivery models is extremely finite and limited. In terms of screening tools, again, I got these from the New York State AIDS Institute website on aging. So the USDA actually has very brief food security surveys, and the Food Insecurity Experience Scale is a global food security survey that is that the WHO has. But both of these are free, and they're meant to be used in clinical settings to quickly identify individuals that might have food insecurity. So I just gave you like a screenshot of what like some of the questions that the USDA food security survey tools address. And then for housing insecurity, the UCSF Siren Network, which is a network that has several tools on it addressing housing insecurity. And again, these are meant to be used as quick surveys in clinical settings so that you can identify patients that are at risk for housing insecurity or suffer from housing insecurity, and you can refer them to the right social services as well. So I've gone through all of these different care domains, given you a lot of screening tools that you can use. But the fact is, how do we incorporate this in our day-to-day practice, right? And we really can't do this alone. Like we have to do so much in a very limited amount of time, oftentimes in our primary care models. And so are there effective models of care for patients living with HIV as they age? And so these are some of the clinics that have been described in the literature. And the key really here, not surprisingly, is that collaboration and integration are going to be extremely important. So in the UK, there is this clinic in Chelsea and Westminster where patients can see their HIV specialist and also a subspecialist if they have cardiology issues or kidney issues. So it's a one-stop shop where they get to get all of their subspecialty or comorbidity care in one place. The Newlands Clinic is a collaboration between in Harare between the government of Zimbabwe as well as a private Swedish foundation, a Swiss foundation, and it's an integrated HIV and geriatric clinic where they can get comprehensive geriatric assessment as well as HIV management, and then they have on-site referrals to psychologists, social workers, etc. The Silver Clinic in Brighton, typically the way that will work is you see an HIV provider, and if you're identified as having aging-related concerns, then you're referred for a more comprehensive geriatric assessment to a multidisciplinary team. This group in Italy focuses on integrated care for metabolic syndrome, and probably the most well-described geriatric care, HIV geriatric care model is coming out of San Francisco in the Golden Compass program, which is part of Ward 86, which incorporates both comorbidity and medical care and HIV care along with socialization as well. And so they offer, in addition to seeing an HIV specialist and a geriatrician, they also get support groups and classes on aging and functional assessments and working on social connection as well. But I think, again, the big thing here is that we can't just do this alone. We really do need to work with geriatricians, with physical therapists, with social workers to really kind of come up with a model that addresses all of these different care domains so that our patients can age effectively. So that's pretty much it. So our patients, as we know, with combination effective antiretroviral therapy are living longer. And with that, they're more susceptible to aging-related syndromes. And so when we approach care of our patients as they age, we need a very structured and holistic approach that takes into account their physical, their mental, their psychosocial need and systemic needs as well. And so we need care models that where we can first assess the needs for our specific patient population. And oftentimes you'll have to go back to your patients, go back to the older patients in your clinic and assess their needs and ask them what they would want also as well as part of their care as they age. And then use those needs assessments to adopt care tools that some of the care tools that you've seen here and other resources to your local needs. And you will need to coordinate this with a multidisciplinary team. And then, of course, your care models need to evolve as your patient's needs evolve as well. And so that is pretty much it. There's like all of these resources, and I've sent my slides and a PDF document with a link to all of these fantastic and free resources that I found. Thanks again for having me, Julie. And I really have to thank a lot of friends and colleagues who shared a lot of resources with me as well. And I'm happy to take any questions.
Wonderful. Wow. Thank you so much, Aley. That was a really great talk with a lot of resources and things to think about, both from the individual patient care level as well as improving our systems. I want to first invite the audience to please put any questions in the Q&A box. You can see, hopefully, Aley, you can see there's lots of claps and love going on for your talk. So we don't have any questions yet, but I have several just to start out. In the
Okay.
meantime, folks, please put some questions in the Q&A box. So I was really interested in that Prepare website, the UCSF tool that you pointed out, and I'll
Yeah.
have to go look at it. I'm curious if you have yet had the chance, or if not, how you would envision incorporating that into your patient care. Would you look at that with a patient in clinic? What are your thoughts about how to actually incorporate that?
Yeah, so I'll tell you, Julie, that I literally found out about this like 2 weeks ago. And I was like, how did I not know about this website? And then I asked a friend, a very dear friend of mine who was a GIM and palliative care attending, and she's like, I use this all the time. I have never even seen this thing referred to in notes for palliative care. So I've thought about this a lot. And I feel like, again, this is going to have to be a multi-step process, right? But probably I was thinking that maybe you would have to set up a visit and maybe have a patient with a tablet to at least start with step one, right? And explaining to them what advanced care planning is, and then they can see a video on this, and then you might have to come back and revisit it with them. And it may not have to be you; it can be a palliative care specialist, maybe a social worker. But I think this is going to have to be something that is incorporated because there's so many steps to it. And patients first have to see the information, they have to assimilate it, and then they have to then think about how they want to go about doing it. And so I think probably like bringing them in and having them see a video, or if they prefer to read. Really, also the other aspect of this is finding out what I think they would prefer, because I have a handful of patients that can't read. And so I can't read or write. And so for them, probably watching the video would make a little bit more sense. But for other patients, they're maybe more tech savvy and they'd be willing to go home and take this material. So I think maybe starting to have the conversation, targeting it towards whatever their literacy needs might be, and then kind of following up with them in subsequent visits is probably the best way to do it. And it's going to have to be an ongoing discussion that probably takes place over months.
Great. That is great advice. I'll look forward to learning more about that.
Yeah,
All
me
right, we
too.
have several questions coming in. First one from Michelle is, what is your advice for nonprofit case management agencies approaching geriatric providers, hoping to incorporate their expertise with our current HIV medical providers? We would like a multidisciplinary approach with systems that don't normally interact.
That is a great question that I'm not entirely that I don't know if I know the answer to this. I think probably you would have to, it would be nice to incorporate to collaborate with nonprofit organizations from from our clinic. And I think you would have to work with leadership, right, to come up with some sort of multidisciplinary approach where you can work with nonprofits to come up with interventions once you do some preliminary, once you assess, once you do your screening and you assess problematic domains. But I think that's going to have to take place probably on a leadership level, right? Between different hospital systems and between your clinic and the nonprofits as well.
Great. Thank you. Yes. And as I think you know, Aley, and just to take the moment to say, we do now have a new geriatric service here at Madison Clinic
Oh,
that's
great.
available for referrals for patients. All right, next one is from Nina Kim. I love the Prepare for Your Care site. The few patients of mine who've done it give it a thumbs up. Wondering what your thoughts are about using the Medicare wellness visits to give us more time to do some of these things.
I think that's a great idea. I have not personally used the Medicare wellness visits, but I think that would be a good time because again, it sounds like you have much more familiarity with this than I do. So, like I said, I only found this about 2 weeks ago, but I think these kind of discussions take a lot of time, and oftentimes in our sort of 15-20 minute session, it's hard to address. And so using those kind of wellness visits to really start to address that is probably a good starting point.
Great. Yes. All right. And then Angelina Platas asks, has anyone looked into using resources such as the Prepare website in a class or seminar setting over multiple meetings? So what do you think about a group approach versus individual?
I think that would be an awesome idea. I mean, I think again, some people, and again, this is where I think you would have to do needs assessment for your specific practice, right? So, there might be patients that do well and would enjoy also the social aspect of being in a class and interacting with other patients who are also aging with HIV, and so this will allow them to see a video, for instance, and have questions. So I think there's many interesting ways in which you can assimilate that model of advanced care planning into your specific practice. Yeah, that's a great idea. I actually probably have to tell people here to use it. So
Yeah, I was interested to hear about the Golden Compass program at UCSF, which sounds like they do group activities as
yeah,
well, if I
yeah.
understood that correctly. Okay.
Yeah, and probably I'm sure someone who's trained it, like maybe someone like Jihan or someone who's trained more recently at UCSF will probably have a little bit more information about how how that's been working too. So
Yes. Do you have anything like that at Grady or elsewhere in the Emory system?
so I just found out that one of our neighborhood clinics has now incorporated a geriatrician, a neighborhood clinic that does primary care, and so they have a geriatrician and a memory assessment program and stuff. But again, that becomes challenging for our patients, right? Because they have to go to a different location, and so we do have a medical home model where we have some subspecialty care here, but I think this is an aspect that I'll tell you, we don't really address very well, and it's very siloed care. And I'm sure if you ask, we have a handful of people here who are primary care docs, but the vast majority of us are all ID, and I can guarantee you that I'm sure most of us don't do this. I haven't anyway, and I think a lot of that is also because I have a couple of younger patients, and my time is seems to be more focused these days on OIs, unfortunately. But it is something that we have to start thinking about. And this having to do this presentation has kind of prompted me to have to meet with our medical director to start to think about how we can address this for our patients as they get older.
Great. All right. Dr. Linda Williamson asks if you can please comment on whether chronic pain is a known issue as people with HIV age.
Um, I think that yes, depending, I mean, it's probably chronic pain related to different aspects, I mean, different parts of living with HIV for a long time. So if you have, say, for HIV neuropathy, patients might have significant pain related to that. Um, Chronic pain can also affect, say, we have a fair number of patients with avascular necrosis. And so that also can contribute to chronic pain. So yes, it definitely can affect our patients living with HIV as they age, and should be a part of your assessment and also your evaluation and your care that you provide for patients, because also how do you manage chronic pain safely with patients as they get older and are more susceptible, say, to the side effects of narcotics and things like that too.
Great. Thank you. Susan Graham asks, to what extent do you interact with case managers with respect to functional status and or advanced care planning? I find that
Not
they
as
often, oh, sorry, she just a little bit more, Aley. She says,
Yeah.
I find they often have talked to patients about these things, and the councils on aging also have great resources that are irrespective of HIV status. Some of my patients are dealing first with these issues for their own HIV negative parents or partners. Sorry, but starting back to remind you, the initial question was, to what extent do you interact with case managers with respect to functional status and advanced care planning?
We again, I'll be honest, I don't. Most of my case management is mostly dealing with social determinants of health when we've been working with navigators and case management. And uh, and I feel like that itself is like a huge struggle working in a state without Medicaid expansion and a lot of limitations of resources. And so we don't really focus on this. And I do think that we need to spend more time. We're clearly not, I know that we're not doing this effectively in our clinic. And a lot of that is because of resource limitations. And it is something that we need to be better about for sure.
Yeah, that's an interesting question. I'd be curious to hear our case management
Yeah.
team's perspective on that here in Madison. All right. Someone without a name here says, there are a few questions in this one as well. Does standard Medicare provide coverage for ART? I understand you might not be a Medicare expert. Please comment on issues. So sorry, this is a little bit about regional differences in coverage of ART and HIV care through Medicare?
So if you have Medicare Part D, it will cover antiretroviral therapy. And someone can correct me if I'm wrong, but I'm pretty sure that that's the case. And in states like Georgia, where we don't have Medicaid expansion, for patients that don't qualify for Medicare, don't have Medicare Part D, we would use ADAP, our ADAP formularies to cover their HIV treatment. And so even in Georgia, we've been able to do that.
Great, thank you. I'm curious, the frailty concept, which we talk a lot about how to measure and the importance of that and the predictive value of that. And it was very helpful to see that table that talked about stages of frailty and interventions, because I think I personally often see a lot about measuring and not as much about intervention.
What to
So I
do,
appreciated
yeah.
that. I'm curious, do you talk with your patients about the concept of frailty? Is that something that you bring into your conversations, or do you feel like it's more of a framework that you have without necessarily discussing it with patients?
I think that I will be honest, I don't really talk to them. I have not. And I feel like now doing this, I, and also as I've had starting to have more patients that are getting older and are actually very much suffering from aging related syndromes, I do need to now start to think about addressing frailty with them. So I feel like I don't do it enough again. And and again, a lot of this is because this was very new to me, and I'm certainly not an expert in this area, but I think that this is something that I do need to address with them, because I can see, like, having now followed patients out for 11 years, I can start, and some of them were over the age of 60, I can start to see that all of these things they're progressing. And I need to kind of think about this with them and how best to sort of to help them manage this.
Great. Thank you. I wonder also, Aley, if you, and I want to invite people, I know there are many
Yeah,
experienced care
please.
providers in the audience, but
Someone else.
you alluded to the challenges sometimes in having advanced care planning discussions with patients, or the stigma, or the I'm a survivor concept. I'm curious if you have found ways to address that, or how you address that when that comes up in your individual conversations.
Yes. This is definitely what this has been, like, probably a very big challenge for me. And so I think for me particularly, like, this has been a struggle in terms of particularly addressing it to the right literacy level. And I'll just tell you, like, last week I saw a very functional 80-year-old in clinic. I was covering a transitional clinic. This patient their provider had just left. And I mean, he's got extremely well-controlled HIV, and he actually has a very good support network as well. And so after doing this whole presentation, I was like, okay, let me talk about this. And I could tell that what I was asking and what he was saying were two very different things. He was like, I was like, have you thought about, like, thinking about what would happen if you were unable to speak for yourself? And what I got back was, I have a funeral plot. I have I have a safe where I have money for my funeral. And I was like, no, that's not what I'm asking.
Yep.
And then I was like, have you thought about what you would want? And he was like, oh, my daughters will make my decision for me. I was like, well, there's that. And so again, like, I think now he's going to be my patient. I'm going to follow him. So now I need to go back to this Prepare for Your Care website to, I think, now really try to think about how to craft this discussion. Because again, I personally have struggled with having this conversation. And like I said, this is clearly someone that thought of himself as a long-term survivor. He's lived with HIV for many years and has done remarkably well, and is a very healthy and very functional 80-year-old. And my initial just even question about advanced care got me. I have like made the financial plan, and I have family, and that's all. And there was no wanting or willingness to, or at least from what I was asking, there was no willingness to think about, like, what he would want to do or what he would want to think about at end of life.
Mm-hmm, mm-hmm. Maybe some of it is over time. He at least has thought
Yeah.
about the end, it sounds
Yes,
like.
yes,
So
yeah.
perhaps
Yeah. Yeah.
that will be an entree into conversation over time. Great. Okay. This says, I don't see any more question and answer. I want to give one more minute for people to put any in. And Aley, after all of this additional Q&A, just want to give you another opportunity if you have anything else you want to leave us with, perhaps from everything you've learned putting this together and what you're incorporating.
No, I mean, I think that for sure, I think the advanced care planning for me was probably the aspect of it that I found the most useful, mostly because, again, this is something for me personally, but I feel like it's a deficit for me that I need to address. But it really just kind of got me thinking about, I mean, like I said, both you, yeah, certainly in Madison and even here for us, I'm very privileged to work in an environment where we have a lot of integrated care. But again, I feel like certainly at Ponce, we are so focused on multimorbidity, and there's just not a lot of focus on thinking about aging-related syndromes, thinking about frailty, thinking about advanced care planning. And I think we really do need to do a better job of doing that because our patients are also getting older, and they're at risk for all of these different syndromes. And I think we need to just come up with a much more effective care model than what we're doing right now. Because I think right now it's just a very, very siloed approach. Like you see the psychiatrist for your mental health, you see me for your HIV and some of your basic primary care needs. And then, and oftentimes I think this discussion of what you would want for yourself happens very much when patients deteriorate, and that should not be when that's happening.
That is a great way to end. Thank you so much for a really excellent talk with lots of resources. I appreciate you sharing your slides, and we can make those available because there's a lot to think about there. And you're getting additional thanks for that excellent talk. So I want to take just a couple minutes to remind people or let people know about what will happen next month. This is the usual third Tuesday, ACC. In October, we will not be having the same ACC, but at this same time and sponsored by the UW Center for AIDS and STD, we will have a talk on HIV and immigrant health by Julie Levinson from Harvard, and you all will see an announcement about that. And we think this audience will be interested and hope many of you will be able to attend that talk at the usual ACC time. So one last thank you very much, Aley, and
thanks
really
for
appreciate
having me.
you joining us today. And thanks, everyone.
Thank you. Bye.
All right.
Bye.
Take care. Bye-bye.